I'm going to do a little bit of why integrated care, even though I'm saying we are going from why really to how and who. The movement to how and who is being driven by all the government health systems, the VA, state Medicaid programs, federally qualified health centers. In other words, the drive from the federal government, from major health systems and from states is very powerful because of the impact that integrated care is showing on cost and quality, particularly now that we have a number of settings, a number of systems that are maturing. When they start out, it's not the most efficient thing to do, but as you get going and as people learn how to practice in integrated settings, the payoffs in the total cost of care are substantial. It is also, to some degree, becoming the latest rage. And latest rage means that anybody who has any behavioral health connected to any kind of medical service is likely to say they're integrated. The term becomes something that people just say, oh yes, we're integrated. There's actually standards. There's definitions, and most of those folks aren't. And so we'll talk a little bit about that area today. But one of the things I want to stress is that integration is not the goal. Better health care for our patients is the goal. And I think well done integration is a way to get there. But if something else was better, I'd be pushing that. Yes, you know that there's a lot of behavioral health need in primary care. I don't need to tell you that. These are somewhat old numbers, I have to say. This group, the PHQ 3000, was a study of 3,000 people who were matched to the overall population of the US. And so this is sort of, if you walk into any, down the street, in any place, on average, these are the rates you're going to encounter. In New Hampshire, these are the rates. New Hampshire is the highest binge drinking state in the country. It's nice to have a record of something, right? And Marillac 500 was 500 sequential patients in a safety net clinic in Grand Junction, Colorado. And what you see is that 2 to 3 times the rate of behavioral health needs. So as populations get stressed, I know I'm not telling you anything, the level of behavioral health needs goes up. And when I show this to a lot of folks who work in these safety net clinics and say any 52% have mental health or substance abuse diagnosis, they say, where is it that low? It's very common to be higher. It's important to keep in mind, particularly in people who are in the mental health world, that most people who have behavioral health needs will not accept a referral to the specialty mental health system, to the mental health center. And so, oh, you can only see one of them. Okay. When you say, if you're a primary care provider in most places, you have, I think you have depression here. we have a screen, for instance. We gave you let's say we give you the PHQ-9, and we say, you're scoring pretty high on this. I'm concerned that you have depression. I'd like you to go to the mental health center and get some care. The chances of people going is well below 50%. And in some places, it's more like 20%. That's before they get to how overburdened the mental health center is, and what the wait time is, and the whole new set of insurance issues and all of that. So screening in primary care and then saying someone go to the specialty mental health center isn't a program. And in fact, the United States Preventive Service Task Force would advise you not to screen if that's all you got. That doesn't count to them as a program. And when we think about equity in care, we have to be aware that racial and ethnic minorities are even less inclined than whites to go to specialty mental health, and they prefer, as a group, getting care in primary care. And so if you're interested in health equity, that's another piece of why behavioral health needs to be in primary care. But it's not just mental health and substance abuse. So this is the top 10 complaints that drive people to adult primary care. And chest pain, back pain, fatigue, shortness of breath, dizziness, insomnia, headache, abdominal pain, swelling, and numbness. And in this study, which was a big study, they went to the provider later, and they went to the health record and said, so in what percentage of these cases was an organic pathology found, either on exam or on a test? Anything wrong? And the answer was 15%. So 85% of these folks had no findings. That doesn't mean that they were all somatizing. That's a big word. What they were all is people who go to primary care. And, but it means that the issues of stress and life pressures and knowledge about your illness and so forth, all of these behavioral factors are major in people's utilization. This is, you are not supposed to read all these numbers. You are to look at them and say, oh, that's a lot of numbers. But what the numbers say is, this is a comparison of these are just chronic illnesses here, and of the cost of people on Medicaid per year for those with mental health and substance abuse comorbidity and those without. And when you total it all up, for 100,000 people on Medicaid, this is in one New England state, for 1 year, the additional cost for people who have mental health or substance abuse diagnosis is $535 million. My friend Steve Mellick made this slide. He is, I guess he's the country's best known consulting actuary on integrated care. And he calls this our opportunity for integrated care. That we're not going to go get all that $535 million, but that's what's out there to, if you could address all of the mental health and substance abuse comorbidities in primary care. And it's not just the medical cost. So I got this slide from Eduardo Sanchez, who at the time was the chief medical officer of Blue Cross in Texas. And Dr. Sanchez wanted to point out that all this that we've been talking about, the medical costs, this includes pharmacy, it includes mental health, it's the whole ball of wax, is only 25% of the cost to employers of poor employee health. 75% of it is absenteeism and presenteeism. Presenteeism is a technical term in the occupational health world, which means I'm there, but I ain't doing much. I just don't feel like it today, and I'm not sure my babysitter's going to stay, and I think I need to leave work to go see the doctor, and all of those costs. If you put those costs into the picture, what you find is that to employers and the cost of employee health, depression is the most expensive illness. And by far the most expensive illness. Cancer's down here. You notice the orange is the actual medical cost. Cancer's a lot more than depression. But in terms of the whole cost, depression is the most expensive illness for employers. Plus, you know, and I know, that there's a behavioral health component for almost every chronic illness. You're going to have, if you're depressed and you have arthritis, your likelihood of doing the moving you need to do or to taking the therapies or the medicines go down. Asthma, how are you going to have an asthma program without smoking cessation? How are you going to have an asthma program for children without smoking cessation for adults? And so in each of these, there's a substantial behavioral health piece if you're really going to do a whole complete program for that chronic illness. So this is a hierarchy of ways that behavioral health and medical services relate to each other. It's a set of categories that I came up with, but it has proved to be durable. And so they're using them in a number of places. SAMHSA created a 6-level way of rating integration, and they essentially put 2 subcategories in each of these to do it. So, but if you're thinking about it, let's just do these. So coordinated care would be behavioral services by referral in a different setting than the medical services, with some sort of formalized agreement about exchange of information. A release on each individual patient that you could do anywhere doesn't count as coordinated. That's just release-driven attempt to share information. I'm going to talk more about each of these. Co-located is 2 services in the same space. So, and by same space, I don't mean upstairs. I mean in the same space. As soon as you go upstairs, the utilization and the connection falls off dramatically. I've been in practices where they had a 6-month waiting list for their own service upstairs. And they also had a 50% no-show rate because after 6 months, nobody's coming, right? So co-located is in the same set of offices, but it's by referral. So we have a mental health or behavioral health service, and we have a medical service, and they refer to each other. Integrated is where there is one treatment plan, and it has a medical component, and it has a behavioral health component, and it may have other components, it may have a nutrition component, but it's one treatment plan, and it's the patient's perception is that I have one treatment plan. And mostly, the patient's perception is these other people are on my provider's team. They work with my provider. And that's what gives us credibility, us behavioral health folks, credibility that we're on the team with the provider. So here's coordinated care. There's not a lot of evidence that it increases effectiveness or lowers costs, but then there are not many programs out there that have achieved basic coordinated care. So how could you not have appointment arrival notification? If I refer you to the mental health center, then when you get there, they will let me know that you came, right? No, they won't. I assume you use the term black hole when you talk about mental health services. Many do. Patients go in and no information comes out. There should be an exchange protocol. So releases would be automatic. The diagnosis problem list and med lists would have to be coordinated so that how could you prescribe in mental health without knowing the primary care med list and vice versa, and have an agreement for how we're going to coordinate, so that if you call your colleague in the mental health center or in the health center to say, I'm concerned about a medication interaction, you get that colleague because they know you might be calling. You're part of their world. They understand you as a partner somehow. This is a model that PCPs, but particularly state health planners, think of first, because they want to conserve their number of, their resources. So they'll say, the mental health center, you guys, will you work with the medical, you work it out. And it tends not to work. This is co-located care. Remember, this is same place, but by referral, 2 different services. And so the doctors will say at the time of referral, by the way, I use the word doctor because the patients use the word doctor. That's my doctor. Mostly, no matter who their provider is. So when I say physician, I mean physician. When I say doctor, I mean PCPs. So the doctor will say, I'm going to refer you to behavioral health. So access is greatly improved, substantially improved. In a study in New Hampshire, they had the same group of therapists available for elderly people diagnosed as depression, and sometimes to a random group was assigned to see those therapists in the practice site, and a random group was assigned to see those therapists in the mental health center, and they would provide a ride to the mental health center so that there was absolutely no problem. They had handled all that stuff, and they had a 50% better uptake just for being located in primary care. So access is greatly improved. Patient satisfaction and provider satisfaction goes up. Everybody, all the providers think, oh, thank God, somebody's here. I can get help with this. Outcomes go up somewhat. The problem is if the people in the space are practicing like they would in their offices, their mental health offices, pretty quickly you have the issues of referrals that don't show up, the issues of the caseload fills up. I mean, if you have X utilization of people going from primary care practice A to mental health service practice B, and now you move that into primary care, and the utilization is now 2x. All of a sudden, these folks, the behavioral health folks, are swamped. And if they're seeing people every hour, they have no chance of keeping up. And when they stop keeping up, they start to get a waiting list, and the providers start saying, why did we do all this? We had all these meetings, and we carved out space for these people, and now they come in and they won't see the patients in the practice. And so many of those programs end, and they don't end pleasantly, because the behavioral health folks feel unwelcome, feel like people weren't nice to them, and the providers feel like they didn't do what they said they were going to do. They couldn't see our patients. And communication is still difficult, because behavioral health folks want to see people hour for hour for hour, and then talk at the end of the day, and they don't, therefore, because they're in their offices, they don't see people in the hall, and therefore the docs are wrapping up at the end of the day, and so it doesn't really increase the fact that they share the medical record. If they do that, that helps a good deal, but it's still a problem. Now here's one step. You have to take a step toward integration from co-location to start making it work. This was a study we did in a FQHC with a brand new behavioral health person there for the first time. And I said to him, this was Nicholas Apostolaris, I said, Nicholas, I want to know every first visit that you have on your schedule, and I want to know whether the person showed up, and I want to know whether you were introduced before that. And the answer turned out to be that it was about double the rate of showing up for the first scheduled visit if he had been introduced to the patient previously by the PCP. Integrated care comes in a couple of models now that are common, as well as every possible step in between. So when I'm describing this, doesn't mean everybody out there looks like this. But the collaborative care model developed out of the University of Washington and was essentially taking the old chronic care model and doing it for depression. So it's focused on a particular illness. You screen to find out who's depressed. You begin with patient education. This person, this clinician care manager, or depression clinical specialist, they started calling them later, was initially nurses. And they were nurses that had a rigorous training program to do this. When they started to spread it to other places, the rigorous training program didn't go along. And so they tended to switch from nurses to social workers and psychologists. It tended to work better to have someone who was able to do this brief structured psychotherapy, which is a piece of it. The primary care physician is important, and the team psychiatric clinician is important. And they draw it this way. So the patient has a lot of connection with this depression clinical specialist or care manager, and who is on a registry. The registry says who the people are in the group of folks who are depressed and where they stand in their treatment. And so because we're monitoring their score on the PHQ-9, we know if they're getting better or if they're not. And the medical provider is, of course, actively involved with the patient. The psychiatric consultant is likely not involved with the patient very much in this model. They are much more involved with the behavioral care manager and with the medical provider as a in consulting. This psychiatric consultant role takes some real shift for people who are trained to be psychiatric clinicians. You end up treating patients without seeing them. That's very hard for many people who have been trained that you're now responsible for this case. If you're having any input on a case, you are responsible, and so you better see them, and you better be your analysis and your assessment. Not in this model. In this model, you're backing up the primary care person and the behavioral health person. The treatment plans are done fairly quickly and with limited information. So we're not going to go back and do an hour and a half seeing the patient and getting ourselves oriented. I mean, one of the things that's different in primary care, by the way, is if you're in mental health and someone walks in the door, you don't know that person. You have a lot of work to do to catch up. In primary care, we know the person. They're ours. So family history, we got it. Medical history's in the chart. So, but this is hard enough for psychiatric clinicians that the training program for that role is ongoing. Let's see if we have the AIMS Center. No, I don't have the AIMS Center here. But the AIMS Center at the University of Washington has an online asynchronous training for free for psychiatric clinicians in how to do this model. And at the American Psychiatric Association, they also are there every year giving the course, because the people realize, funders realize, this is not a thing that someone can just decide, okay, I'll do that, because they have been culturally taught to do it very differently. And it needs to be taught by someone who has credibility. So someone like me, psychologist, I will not be able to teach that course because I wouldn't have any credibility. This was the first run of the difference between regular care and care in the CCM model. This is 6 months, no, this is 3 months, 6 months, and 12 months. And what you see is the results are more durable and substantially different. This is now the other model of primary care in behavioral health. And this picture starts out because this is a real picture. BHC stands for Behavioral Health Consultant. I like to say Behavioral Health Clinician because your role really is broader than just consulting. One of the reasons the term consultant was used was to begin to change the mindset of both the behavioral people and the medical people about the idea of just referring. You know, we'll bring in so-and-so, the behavioral health person, and now it's your patient. And so to get both the provider and the behavioral health person past that idea, they stick to the word consultant. I think once you get going, behavioral health clinician works fine. So you're managing the psychosocial aspects of chronic and acute diseases. You're applying behavioral health principles to address lifestyle and health risks. And you're consulting and co-managing the treatment of mental disorders and psychosocial issues. You aren't the manager of all the behavioral health things. And the goal is to return the patient so in a state in which the PCP can manage the behavioral health issues. This is both a real architectural drawing and a metaphor. This is from the Cherokee Health System's flagship health center in Knoxville, Tennessee. And you see how they built this. Here's the behavioral health consultant's office. On each side, there are 3 exam rooms, and this little thing is a shelf. And the doctor and the MA do their charting there. And so this is, they can access this person immediately. And because behavioral health is the universal comorbidity. And so if you're serving a stressed population, there's going to be a behavioral issue everywhere. And so instead of having one person here to serve 7 providers, 8 providers, no, this person is serving 2 providers for a highly stressed FQHC population with a fairly high homeless population. This is my reflection of my conversation with the psychiatrist that I met at Cherokee, named Greg Perry. I love him because he has a past. And his past is that he was a music director for Dolly Parton. And if you go on the web and see Greg Perry, put in Google Greg Perry, you will see pictures of him and Dolly, and it looks pretty cozy back in the day. So at any rate, at some point he decided the music business, it wasn't for him, and he went back to medical school. And now he's the chief psychiatrist there. He does most of his work in video consults, telehealth. And so I learned a great deal in one visit, which is, first of all, telehealth to him is not talking to patients only. It is maybe talking to patients, maybe talking to PCPs, maybe talking to the PCP and the patient, maybe talking to BHCs. In other words, he's doing a full range of contacts. And he said that he can support a practice of 5 PCPs on 2 hours a week of his time, because they have centers all over the mountains of East Tennessee. And what makes that work is he's also available by phone. And so what's very common is, he says, I have 3 usual patterns of involvement in a patient's care. One is I see the patient, their clinician, or both, one time and offer consultation on treatment planning. And that's the most common interaction he has. Second is, he says, I see the patient 3 to 5 times and I prescribe for them. And when I think they're stable on a medication regimen, I pass that regimen back to the PCP. And the PCP prescribes. And the PCPs are willing to do that because they know they can get them on the phone. If PCPs feel alone with this complex psychiatric regimen, they don't feel comfortable and they don't want to do it. But if they know they can get them on the phone, if something goes wrong, they are comfortable. And he says, sometimes I see the patient enough visits to determine that the management of their psychiatric needs can't be in primary care. And so I make sure that they're referred to specialty mental health and that the PCP does not manage their psychiatric meds. And the other piece that makes this work, by the way, is the nurses at both ends of wherever he's talking. And so he has these highly organized folks who are making sure that it's now 7 o'clock or whatever it is, it's now 10 in the morning, and at one end he has all the information he needs to have in advance about who he's going to see next, and in the other end there's somebody making sure that who he's going to see next is sitting right there and it can be turned on and they can be right in the middle of some useful exchange rather than losing time to technology or lack of coordination. This is data from Blue Cross that was given to the Cherokee Health Systems about their costs. And what the data was that compared to, this is the utilization level for other regional health systems of Blue Cross. And what they said is, gee, you guys, you use a lot of primary care visits. However, ER visits, a third. Specialty care and hospital care, not quite 2/3. Here's 3/4 the cost. So they save 22% over the average from the way they're organized. And this is the place where integrated care has been a very long and very honorable history. But these two models are now converging. Collaborative care was disease-based. This is program-based. In other words, the primary care behavioral health model is behavioral health becomes infrastructure. It's just there. And so, for instance, these have strong outcome evidence. This has strong satisfaction evidence with outcome evidence for mature programs. Nowadays, here, the depression specialist sees other kinds of concerns as well. It just wasn't viable to say, I'm sorry, I only see depressed people. If you're anxious, I'm sorry, I can't talk to you. And no, that happened. That happened. And I went and consulted in Asheville, and they had recently, the providers had terminated the integrated care program and refused to cooperate, because when the behavioral health person came in, said, if this person's depressed, I'll see them. If they have anxiety or something else, I won't see them. And the providers wouldn't have it. And so they had retooled the program to be a brief intervention program for whatever needed intervening. So this is a definition of integration that is accepted and was developed by the Integration Academy, which is funded by AHRQ, the Agency for Healthcare Research and Quality. And it says care that results from a practice team, that's a big piece, primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach through patient-centered care for a defined population. May address mental health, substance abuse, health behaviors, including their contribution to chronic illnesses, life stressors and crises, stress-related physical symptoms, and ineffective patterns of utilization. And I promise not to keep reading you the slides. The last piece, so in general now, we've looked at two approaches to psychiatric services in primary care. Here's a sort of the generalized one, and it involves the psychiatric provider much more as a consultant, much less as a provider. In the practices that I was involved in, the thing that made the difference was when the psychiatric provider stopped prescribing. And at that point, then you couldn't, as a PCP, send somebody to the psychiatric clinician and they would do all the prescribing, and then you didn't have to talk about that anymore. So you still were going to be the prescriber, you just got consultation. And that shifted the mindset a lot. One of the things you might be interested in knowing is that when we surveyed safety net clinics in the state of New Hampshire, we found that they were twice as likely to be using psychiatrically trained nurse practitioners as psychiatrists. And they were happy with that. There was a little bit of issue of cost, but there was also a lot of folks saying this is a good thing. It works for us better. Interesting, quick. You should know about the MCPAP program. That's the Massachusetts Child Psychiatry Access Program. And it has made a monstrous difference in access to psychiatric services for children in Massachusetts. Because in Massachusetts, if you are a pediatrician or family doctor seeing a child, you can get a psychiatric clinician on the phone in half an hour. There are psychiatric clinicians standing by, just like the operators who are standing by to sell you the Ginsu knives. Now, psychiatric providers are standing by. And that meant that the need for the waiting list at psychiatric children's services went way down because the clinicians, primary care children's clinicians, just needed to be confident when they took some of these steps, make a big difference. But it's not easy. We've been talking about psychiatrically trained clinicians having to change their thinking. Well, so do us non-physician folks. When we get to primary care, we find patients that we never saw before in mental health. These are folks who are not as acute necessarily, but most commonly, they're people who came for what they think of as physical concerns, and they end up working with me. But if I spent all my time trying to talk them into a diagnosis, we'd waste a lot of time. So I'm talking about how we can help you with your stress and how we can help you manage the problems with keeping up with your diabetes. And I had to learn to be comfortable with that. For many of us who were trained, the status as ancillary provider is new. And on the other hand, I have to say, I've never been appreciated more. In mental health, another psychologist, what's exciting about that? In primary care, we have a psychologist. This is fantastic. Where is he? And so it's very rewarding to be there. We have to learn different routines of time. I never saw somebody longer than, or I never scheduled anyone for more than half an hour in my work in primary care. Sometimes it was shorter. People have a set of goals. They're working on it. They come in. We look at their tracking of their goals. Good on you, and go on out. Confidentiality is a challenge for many of us who were brought up in the mental health world and its culture. The culture in mental health is the unit of confidentiality is the clinician and the patient, and that's it, unless the patient insists on somebody else knowing. In primary care, the unit of confidentiality is the team. And if it weren't the team, the patient gets much worse care. And so we have to learn to be comfortable with that. It comes up all the time, particularly as people move into this. For a generalist behavioral health clinician like myself, it actually takes more training, not less. Even if you're talking to somebody for half an hour, we have to be comfortable with care management, brief therapy, behavioral medicine, do relaxation, biofeedback, hypnosis, health behavior change. Got to be able to work with families. We do substance abuse engagement and counseling. Now the behavioral health piece of medication-assisted treatment is becoming more and more primary. Not that everybody who is getting Suboxone should have a counselor. That is not the case. That has not proved to be the case. But having behavioral health as someone who assesses everybody who's going to get a prescription or who is available to or who can teach other ways of managing pain or of managing anxiety. It's a crucial piece of the teams. So it's a matter more of skill set and fit. This is a struggle for us folks in the academic world where you're training one kind of people. And there's a certain amount of competitiveness among the disciplines. I know that's a surprise, but I'm just going to tell you. And competitiveness just doesn't fit in primary care. You're going to be on the team, and so you have to be somebody who's comfortable working on a team, making relationships with everybody, because the people at the front desk, the people who do the billing, you're going to be inconvenient for them. If they haven't had behavioral health before, you do things differently, you're just going to be a burr under their saddle unless you have a good relationship. You have to be willing to dive into ambiguous situations. This is new to you, and nobody knows how to tell you what to do. So it's not like the provider's going to come out and say, here's what I want you to do, I know exactly what. No, they have no idea. They say, okay, help out if you can. Over time, working together, they become very clear on what you can do. And everybody's expertise gets better. But initially, it's a challenge. And you have to show assurance and confidence without misrepresenting your knowledge. And that's a challenge, because we're used to saying, well, I don't know, it's not for sure, it might work out, it might not. If you say that to many providers, they'll say, well, then why are you here? If you don't know what you're doing, well, I guess I really do know what I'm doing. No, you just act like you know what you're doing, and when you don't know what you're doing, don't go there. Just say, in this area, I'm not the person. Care management is a big piece of this, because the social determinants of health are so big for so many of our patients. The fact that tends to be two discipline approaches to care management. Mental health has case management. Medical has care management. Care management tends to be nurses in a number of situations. The mental health folks really don't know much about chronic illness, and the care managers are uncomfortable with behavioral health. There's been studies of nurses leaving their positions because they were asked to add behavioral health as a basic piece of their job. At UMass we have that's still there. I'm not there. They have a training program to sort of train both of those folks, so that the idea is that we ought not to have two roles, and the one person who's there ought to be able to handle, at least to a minimal competency, both behavioral health and medical issues. Here's the workforce, which is evolving quickly. This is our website, and on that website you'll find video training modules for primary care of children, orientation of students to pathways in primary care behavioral health, training for practice facilitators in integrated health, and training for APRNs on behavioral health integration, which we are now creating. There's also detailed descriptions of roles and duties and training required, salary ranges, and career ladders for how one could move, for instance, from being a community health worker to being a health coach to being a social worker or a mental health, licensed mental health counselor without leaving their job, because folks can't give up their check in order to train for the next piece. The job descriptions are remarkably complex, or the picture is. We reached out to a Southern New Hampshire Health Center and a Northern New Hampshire Health Center. We said we want the job descriptions of everybody who sees patients in any role except providers. I don't want the providers. And in one, there were 18 job descriptions. In the other, there were 15. So the idea that we have the same old, there's the doctor and the nurse and the this and that, that's long gone. The complexity of what the roles in primary care is substantial. I want to do a little bit of what this might look like on the ground. How would you do some of the routines of team-based care? One of the ways one of the problems that needs to be solved is, what does the primary care provider say about this behavioral health person? Because I was there when they didn't know in the place that I came in, and so the provider would often say, this is Dr. Blunt. He's are you a psychiatrist? No, you're a psychologist. Oh, he's a psychologist. You should talk to him. And it tended to be pretty uncomfortable between myself and the patient at that point. Where are we going to start? Why are we having this conversation? Patient looks at you like, I'm not sure who you are. It isn't a good way to start. So I developed a training, mnemonic, SSRI. I thought, okay, the medical people can remember that. And so it stands for situation, skill set, relationship, and indicators. The situation, and this is what the PCP is saying to the patient and to the behavioral health clinician once they're in the room. And we want it to be in the room, not in the hall. You want the patient to see the next person get oriented to their situation. If you go out in the hall and you don't say God knows what, as far as the patient's concerned, and then they come in, the patient has no idea what the new person knows about them, it's much, much harder. So in the room, the provider says what the situation is in the patient's care that makes the primary care provider want to involve a behavioral health provider. So this is Ms. Ruiz. She has terrible headaches. I think they might be related to stress. Doesn't have to be long. Doesn't have to be a million words. But why are you bringing this person in? What are the particular skills that the behavioral health provider brings that are helpful to the overall treatment? In other words, saying, this is Dr. Blunt, he's a psychologist, is as much of a game stopper as it is a game starter for many people. On the other hand, this is Dr. Blunt. He is an expert at helping people cope with the stress that makes their headaches worse. I am. So now the patient says, oh, he's the guy for me, because he does what I need. Here's an example. This is an actual text of a note. Kathy reports still feeling depressed a lot of the time. Suggested she might make use of counseling service here in the practice. Says she would consider, but does not want someone all nice and happy. Refer to Dr. Blunt, who is neither nice nor happy. I have that note, a copy of it, in a frame in my office. I love it. You can tell that this doctor is one of my good friends. But Kathy thought it was pretty funny. And so it got us started. What you need, I got. Relationship. What is the relationship that the work with the behavioral health provider will have to the current treatment plan? Not relationship between me and the patient. We're going to be pals. No, none of that. The work with Dr. Blunt is going to help with your headaches. And indicators, how would we know it was helping? What would indicate that this work was adding the value that we hoped it would add? There's a book out now called Behavioral Health Integration in Primary Care. Your Patients Are Waiting. It's from Springer. It's edited by Stephanie Gold and Larry Green. Gold and Green. Sounds like a high school team, right? And they, and I have a chapter in there called The Teams, or something about the team. And in fact, we do go through the SSRI with lots of examples of actual words people would say. If you're going to be talking in front of the patient, though, some of us need to work on our language a little bit. And we may have to learn a little bit about reframing. So, we have to learn to change our language in order to engage and activate patients, from the sort of negative and passive way that they get described in professional language. Professional language is not insulting, or is not designed to be insulting, but it has an assumption within it about this person as someone that we are helping and that they have all the needs. And we need to move it to more positive, active words, because we're going to be telling them that they should be managing their illness. Well, how are you going to do that if every bit of language you use says, you're a patient, we'll help you, this is the treatment plan, we'll make you better, except now you should be handling all of your needs. So instead of saying somebody suffers from the illness, they struggle with the illness. They're a person, they're working on it. There's studies of how much time and energy people put into managing a chronic illness, and it's substantial. Not that he refused to take the medicine, he decided against it. If he decided against it, he could decide for it later on. He's a decider, not a refuser. Refusers keep refusing. Didn't keep the appointment, was unable to be here. That would be the common courtesy I would expect, because I wouldn't not keep it for no reason. Was non-compliant with, had not seen the value of. Doesn't that just change who should go next? If he's non-compliant, well, we can all just sit here and do nothing till he decides to comply. If he hadn't seen the value of it, that's kind of on us, because isn't that our job to convey what the value of this treatment plan is? He arrived late, was determined not to miss. Most powerful thing up here is that one thing in terms of how you can make a change immediately. When I go out to the waiting room and I get somebody to see me and they're 20 minutes late, and the nurse has already come and said to me, do you want to see them? They're 20 minutes late. We can turn them away. And I say, no, I'll see them. And I don't yell at the nurse because those are the rules. I know. So I bring them back and I say, thank you. And they say, thank you for what? And I say, for continuing to come. Most people, when they're running 20 minutes late, give up and go home. But here you are. You know, I just have a feeling that you have a commitment to your health that you and I can base something on. I'm really glad you kept going. Let's do the most for you we can in the time we've got. Does that make sense? And you can get together with folks and the list goes on and it takes a lot of, it's fun though. So we're at question time. What, do you have questions? Actually, I know you have questions. The question is, are you willing to ask the questions? Yes, please.
This all sounds great.
Right.
How to make that work within our healthcare system? I don't know what the figure is for the average nurse practitioner visit in primary care, but it's not that much more than the 7 minutes we have been fed about physician time.
Yeah.
how are we going to pay for that as a culture?
As a culture, it's easy. As a payment system now, it's not easy. So in places where, for instance, the transition has been made to a different payment system where it's all on a per member per month system, that's when the savings of integrated care particularly kick in, because the place where the savings come is in lower ED use and lower inpatient use by and large, as well as some lower primary care use. But what you're facing is if we have no other solution, what can we do? Which is just push harder, just do more, and eat the fact that you know you didn't do as much for that person as you know how to do. And so we have a burnout rate now that is skyrocketing. And what are we doing about it? We're selling mindfulness to the providers. Well, mindfulness is good, but that's not what we need, right? So in general, adding behavioral health in primary care, because that handoff that I showed you, 2 minutes about that, adds minuscule time and tends to make you less used by the people who tend to want to push you for not 7 minutes, because I know there's some where you run to a half an hour and you run over because you can't do anything with them. So when they did a study, or a study was done in a pediatric practice in Tennessee, mountains of Tennessee, and they sent a graduate student psychologist to the practice 1 day a week. And they kept track of all their billings by day. And what they found was, on the day she was there, the practice billed $1,120 more than on other days, on average. And they didn't pay her, and they didn't bill for her. So the extra billing was in increased provider time, because the providers would say, oh, here we go. We're going to have a long conversation about toileting, and this is half an hour. This is 45 minutes. Let's get Miranda. And so Miranda comes in and said, I'd love to talk to you about toileting, and let's please go over here. And so then the provider sees more patients. So the extra money was in more people seen by the provider. So in the bigger picture, it actually works at the absolute level of, this is our schedule now, and what are we going to do now? It can be pretty scary. And the other thing is, you're going to need support from the top. This is not, I did what I call backdoor integration, which is, I show up there because I'm a faculty member and they have to have me, and I say, I'm going to see my patients here too. And so then I set about trying to talk people in to being more involved, and we could do this and we could do that. Nowadays, it's got to be front door integration, so that the medical director and the CEO and so forth are on board and are saying, we need to do this. And at that point, it shouldn't be the individual provider saying, oh my God, how do I do this? There should be a group in the practice saying, we're figuring this out, and that's a very real problem. I know that doesn't fix it for tomorrow. Okay, yes?
This is kind of a perfect segue in the context of New Hampshire now having the hub and spoke for substance abuse, which
Yeah.
is now, I guess, being called the doorway. Can you give us a sense, I mean, this might not necessarily be in New Hampshire, but how other states have kind of integrated medically assisted therapy, substance abuse treatment, especially, federally qualified health centers and those sorts of things, with mental health as well?
Mm-hmm. And I don't know, I don't know whole state programs as yet. There are whole state, I guess, wishes that it would happen. But the Integration Academy, I'm a member of the Integration Academy, and we have a grant program where we have been given money to give to people who are starting MAT programs in health systems in different states. And what we find is that the behavioral health piece and the MAT piece gradually become more comfortable together. Initially, MAT is sort of very separate. It's separate because it's new to the providers and they're trying to figure it out. And there's all of this practice-wide shifts that have to be made. People at the front desk have to be oriented and they have to be supported. What if someone comes in and yells and makes noise and so forth? And so they're all, how are we going to do all these urine screens? All of that stuff is new stuff. As it settles down and as people get more comfortable with it, the fact that someone could be doing fine on Suboxone, but their marriage is breaking up, and they would like somebody to help them with that, because if we don't help them with that, their risk of going back to using gets worse, right? So that becomes, this is then the PCBH, which is the behavioral health as infrastructure in the practice, that we have somebody available and they do a lot of different things. We are generalists, like our medical colleagues who are generalists. Is that fair? Okay. Others? Yes.
I teach at UNH, and we have a very popular postmasters, psych mental health nurse practitioner program, which is a year's training. And so when in practice we've had our graduates, I mean, it's very difficult to integrate that. If you want to stay being the primary care provider, but then overlay now new expertise in psych mental health, just the billable out, I mean, the time
yes,
it takes. And
it is.
I think that I would like you to speak to that. But to another thing in New Hampshire is that we're now involved in Project ECHO, which is for,
yes,
in the rural areas. There's telemental health consultation available, which is
right.
a really great program that.
There's a Project ECHO on MAT coming up in New Hampshire. There's one going out of UMass Medical School. Some of my colleagues are involved in.